welcome everyone, and good afternoon. We are in the afternoon now, I have to remind myself of that. My name is Katie Schubert. I'm President and CEO of the Society for Women's Health Research, and we are really appreciative and grateful of you spending your time with us today to talk about a really pressing issue that I think obviously you're all interested in, but really thinking about policy pathways to addressing obesity disparities in women. And this is especially timely just given the reintroduction of the bipartisan, bicameral Treat and Reduce Obesity Act, or TROA, one of the few things maybe everyone can agree on that needs to be addressed over here. So we'll see how that goes. We'll keep our fingers crossed. So today we're going to explore obesity. We're going to provide an overview of the landscape of obesity in the United States, and especially its unique impact on women. And given the many, many conversations that are happening here on chronic disease prevention, our panelists are going to share how focusing on obesity at a national level and implementing policy solutions to tackle obesity will simultaneously help support those national efforts and how we can address chronic disease in this country. Our mission, for those of you who do not know, is to advance women's health through science, policy, and education while promoting research on sex differences in disease to optimize women's health. And we were founded 35 years ago to make women's health mainstream. And what does that mean? That means that women's health is not a special issue, a niche issue, or something that has to be considered after the fact. It is baked into the healthcare ecosystem from the beginning, from basic research all the way through to translation of clinical care. And our obesity program is part of our Healthy Aging Network, which touches issues including Alzheimer's disease, of which 2/3 of patients are women and a majority of caregivers are women. Bone health, so we know that osteoporosis affects like 80% of women? Did I just make that up? Okay. 80% of women. Heart health, which presents very differently in women and men, although I would note that cardiovascular disease is still the #1 killer of men and women in this country. And menopause, or as I like to call midlife, healthy aging, and thinking about well-being and risk of chronic disease and conditions during that transition in your life. So there's a lot going on in our Healthy Aging Network, and with most of our programs, we entered the obesity space by convening an interdisciplinary group of experts, which span researchers, clinicians, patient advocates, and policy experts to discuss the gaps and opportunities that exist for women living with obesity. And our current work builds on that, specifically looking at the intersection of obesity and women's health, with an emphasis on improving the understanding of comorbidities, interventions, and outcomes for women living with obesity. And we're excited that we have many of our working group members here today. We had a really fantastic day and a half talking about this issue and really uncovering a lot of needs for women living with obesity and their families, quite frankly, and really robust discussions on topics like metabolism, the intersection of obesity and heart health, and we've heard very powerful stories from women who are speaking out about their experiences to help drive meaningful policy solutions forward. Our two very fierce advocates who joined us yesterday. I wonder if our working group members wouldn't mind just raising your hands so that we can thank you here in this venue. Thank you. And we've been just tremendously grateful for all of the support of our partners and subject matter experts who have joined us to have this conversation. And the truth of the matter is, as a small organization, we are small but mighty. We are not able to do anything without collaboration and partnership. And it's really important to us that we help to amplify and support those voices in a variety of health issues, disease states, and life stages. And so that's really at the core of what we do and how we do it. And of course, I need to thank the sponsor of our program, Novo Nordisk, and I would also note that we maintain editorial independence and control over all of our programming and content, as well as our work products. But again, we wouldn't be able to do what we do without the support of our sponsors. So with that, I would like to introduce our panelists first. And then we have a special guest that I'm going to intro as well. So first of all, thank you all for joining us again. We have Dr. Lydia Alexander, who is a leader in obesity medicine, lifestyle medicine, and internal medicine, certified by both the American Board of Obesity Medicine and the American College of Lifestyle Medicine, and is the past president of the Obesity Medicine Association and the chief medical officer at Inara Health. Among her many achievements, which include being medical chief, trained at Tulane University, medical chef, trained at Tulane University's Goldring Center for Culinary Medicine, Dr. Alexander earned the Obesity Medicine Clinician of the Year Award in 2018 and the Dr. Raymond E. Dees Meritorious Service Award in 2019. Next, we have Sarah Brown, who's the Senior Director of Government Affairs at Prevent Blindness, where she represents the lived experiences of people with vision loss to policymakers in pursuit of policies that prevent blindness and preserve sight. Since joining Prevent Blindness in 2017, Sarah has grown the organization's presence on Capitol Hill with the administration and amongst stakeholder groups in pursuit of Prevent Blindness's policy goals, strengthening federal investments in vision and eye health programs and improving access and coverage policies for eye health patients. I was just spending a little time with her CEO this morning, and we were talking about how many times people forget the eyes when they are thinking about what's happening in the healthcare ecosystem. So we're pleased to have you as well. And then last but not least, Dorothea, oh my gosh, I'm gonna get it so wrong, I'm so sorry. Bathiatis, and I practiced it, I apologize. Who oversees the strategic program operations for the National Council on Aging's health portfolio. Her team manages numerous grants and engages community-based organizations nationwide to support older adults through services and evidence-based programming. She also builds alliances and leads collaborative initiatives that focus on educating and raising awareness about chronic diseases and advocating for policies that protect the rights of older adults, promoting nutrition security, addressing social isolation, and enhancing behavioral health, which is so important as we're thinking about these issues surrounding healthy aging and living well as we age. And so with that, I would like to introduce, before we get to our panelists, our special guest today, Congresswoman Chertoff McCormick, who is a SWHR heart health champion, but a stalwart and fierce advocate in the obesity space. I also love her suit. Congresswoman Chertoff McCormick is serving her third term in Congress, representing Florida's 20th district, and she serves on the House Committee on Foreign Affairs as the ranking member of the Subcommittee on the Middle East and North Africa, and on the House Committee on Veterans Affairs. She's chair of the Global Women's Issues Task Force for the Democratic Women's Caucus and serves as a member of the Congressional Black Caucus. And especially relevant to today's briefing, the Congresswoman has been a champion, as I mentioned, for women living with obesity. Earlier this month, she and some fellow members of Congress sent a letter to CMS Administrator Dr. Oz urging him to preserve and protect access to anti-obesity medications for Medicare and Medicaid beneficiaries. And last year, she led the March 2024 resolution recognizing the urgent need to prevent and treat obesity as a disease, and in December, along with Congressman Mike Kelly, introduced the Dual Eligible Americans Living with Obesity Act, which would provide coverage of weight loss drugs under Medicare Part D for duly eligible Medicare and Medicaid beneficiaries living with obesity. So really, really important policy solutions here. So thank you for joining us, Congresswoman. Thank you so much.
Good afternoon, everybody. So I'm Congresswoman Chertoff McCormick. I'm super excited to be here because in Congress we run around all day, and it's not every day you get to talk about a topic that you're passionate about, a topic that you've watched your whole entire life. People assume, well, you know, you're just going to be obese as you get older. You're just going to have comorbidities in your life. And you know, you just might just have a heart attack, especially if you're a woman who's between the 50s and the 60s. That's just what happens in our neighborhood and our communities. It wasn't until I actually got older. Now, mind you, my family's from the Caribbean, and we just pretty much watched everybody who would gain weight, have heart attacks, have strokes, be bedridden, or be in wheelchairs. Just life cut short very quickly. Some of my aunts couldn't even make it over to their kids' graduation because they had a stroke. And this is kind of the thing that you felt like, well, this is inevitable for us and how we live. But truthfully, it's not. It was an issue that was never really being addressed. It was an issue that wasn't even being looked into. And so as I started, having my children and looking at it, and I came to Congress, I probably at that point, with all the stress of Congress, my doctor was like, well, you know, you keep on being in there. At that time, you have to have been like 250. And they were like, well, you need to do something because at this rate, now you're pre-diabetic, your cholesterol's up, we're about to put you on medication. At that time, I could have been probably 42 years old. And I had 2 kids who were graduating and going to college. And I know I've seen this so many times in my life before, and I said, I can't be that person. I can't disappoint my children. I have to be there for them. I have to be there for my family, but I had to be there for my constituents. And then I started educating myself more, and I came from a background of healthcare. So I knew exactly what this was, and I saw the disproportionate impact when it came to certain individuals. If you had money, you didn't have to live that life. But if you were a hardworking American, taking care of your family, putting your kids through school, just trying to make a living, you suffered that fate. And it was I felt like it was just not fair, that hardworking people are being subjected to this. And then I started realizing that there's solutions. And when we started hearing about these solutions, some people tried to make it seem that it was a task in vanity. It was not a task in vanity. It was about survival and keeping our families together and making sure that everyone has a chance to see their kids grow up and even their grandkids. And so that's when I said, you know, this is such a real issue and that there's ways. And I said, I'm going to take the chance and actually try it for myself. And within a year, I lost more than 100 pounds. But that's not the biggest change that happened. I was no longer pre-diabetic. My cholesterol was gone. I became a different person. And I said, oh my God, I might live to see my grandchildren. Everybody should have that opportunity. And I think anybody who tries to demonize or stigmatize any person, man or female, who says, you know what, I want to live longer than my parents. I want to live longer than what people are predicting. I don't want to live with congestive heart failure. I've seen that happen before. You're suffering. Why shouldn't they, because they don't have the money or the accessibility, be denied a dignified life? And that's when we started being more aggressive about telling the story and about how, if we're talking about equality when it comes to healthcare, this is our starting point. It's too many times we try to deal with it when it gets to the comorbidity stage, when it gets to diabetes, when it gets to congestive heart failure, high cholesterol. That's when we're trying to say, hey, how can we roll with that? But what about preventing it as it starts? What about doing it early on at a cheaper rate? And so that's why we push so many bills. That's why we support so many great organizations. That's why we fight every single day. Because for me in our office, the work will never be done until we come to the place of healthcare equality. When we get to a place where you could be the wealthiest person in America and the poorest person in America, and you have the same rights and the same availability to survive and to live a healthy life, that's when our job will be done. So I'm so proud to be here, and I'm so proud to see your faces here, because you are helping all of us get to that place of equality. You're helping everyone feel free to actually talk her story, and to dispel these stories about it's just vanity. Go work out, go do these things. It's much more than that. And science is starting to prove that. And so I'm happy we're taking it seriously, but I'm even more happy that you guys, who are our future, who are our present, who labor in this every single day, get to be here and talk about how we can continue to carve out a space where people can hear and we can help solve this issue. So thank you so much for what you do. Thank you, Keelan. Thank you, all of you. And if you ever need anything, our office is always available. And if you have any legislation that we need to push, we are so happy to do it. Just reach out to us. And anytime you want to visit Florida, we're always here. I'm Congresswoman Sheila Shepard-McCormick, and thank you so much for the hard work that you do.
I'm Dr. Lydia Alexander, an obesity specialist and immediate past president of the Obesity Medicine Association. I've spent my career, the past 15 years, helping patients understand, manage, and treat obesity as the complex disease that it is. Not a lifestyle failure, not a moral issue, but a serious, treatable, progressive, and relapsing condition. And we can see here, as I manage all of my media, what is obesity? And as I've mentioned, it's a chronic, relapsing, progressive, and very importantly, treatable disease that occurs when there's an increase in the size and amount of fat in the cells in the body that cause metabolic dysfunction and weight dysregulation. It's not simply eating too much or moving too little. It's caused by a multifactorial mix of genetic susceptibility in some of us, in many of us, hormonal and metabolic imbalance that then occurs, socioeconomic forces, environmental exposures, psychological and medical factors, and even the medications we prescribe to treat other conditions. What we know about obesity is that the magnitude of obesity is very difficult to overstate. Nearly 75% of adults in the US have obesity or overweight. It's associated with more than 250 diseases, some of which are on this slide in front of us here today, from diabetes to dementia, as well as to eye health. 85% of individuals with type 2 diabetes have overweight or obesity. So obesity is the root cause many times of many of the other chronic conditions that we are treating as physicians, and we are seeing our physicians and other clinicians for on a day-to-day basis. It contributes to nearly 500,000 deaths per year. In 2016, excess weight reduced life expectancy by 2.5 years, more than smoking. And for women, this burden is even greater. Women are more likely to experience obesity-related disability, stigma, and chronic illness. Obesity increases the risk of 13 different cancers. 4 of them are unique to women. Uterine, breast, ovarian, and cervical cancers are all increased as a result of unhealthy weight and metabolic dysregulation. Cardiovascular disease, which Katie mentioned is the #1 killer of women, is made worse by obesity. In fact, relative mortality rates from obesity are nearly twice as high in women compared to men because of these different issues. And #1, cardiovascular disease, #2, cancer are the 2 largest killers of Americans. We must also talk about the lifespan and the impact of obesity in women. In puberty, obesity in adolescence sets the stage for lifelong disease. It's linked to early onset PCOS, polycystic ovarian syndrome, a major cause of infertility and diabetes in women. 1 in 3 women now enters pregnancy with obesity. That increases her risk of gestational diabetes, cesarean section, postpartum hemorrhage, and long-term obesity in both mother and child. As estrogen declines, women gain an average of 1.5 pounds per year and as much as 5 pounds per year, mostly around the abdomen where there is risk for visceral adiposity and increase in cardiovascular disease risk. And this happens in midlife and menopause, which then predisposes again to the vicious cycle of type 2 diabetes, heart failure, and fatty liver disease. In fact, heart failure with preserved ejection fraction, known to us clinicians as HFpEF, is almost entirely a condition that women suffer and is preventable with treating women who have obesity and overweight. The good news is that the hopeful message is that we know obesity is treatable. We have tools, lifestyle intervention, nutrition therapy, physical activity support, behavioral medicine, and now evidence-based anti-obesity medications. Studies show that treating the root, so obesity itself, leads to, again, fewer diabetes diagnoses, lower cardiovascular events, reduced cancer risk, and longer, healthier lives, improving our quality of life, not just longevity. But access to these treatments is not equitable. Many private and public insurers still refuse to cover obesity medications. Obesity is one of the only chronic diseases where coverage is routinely denied despite the science. And clinicians are not consistently reimbursed for diagnosing and treating obesity. We cannot close the gender health gap if we continue to ignore this. We need to invest in precision medicine research to better understand how obesity affects women differently than men. We need to answer questions like, why do some women respond to treatments and others don't? How do hormones, menopause, pregnancy, and social determinants of health change risk? What are the barriers that keep women from long-term success? And we need to support diverse clinical trials that reflect women of all ages, races, and backgrounds. Here's what I hope you will take away from today. Obesity is not a failure of willpower. It's a chronic disease requiring medical care. Women are disproportionately affected by obesity across the lifespan, from puberty to childbearing ages to perimenopause and menopause. We have the tools to treat it, but we need policy and reimbursement to match the science. Treating obesity will improve women's health and reduce risk for cancer, heart disease, diabetes, infertility, and more. Let's stop treating the fruits of obesity and start treating the roots. Thank you.
Hi all. I'm Sarah Brown. I'm Senior Director of Government Affairs for Prevent Blindness. I thank the Society for this opportunity to bring another perspective to obesity and the obesity crisis that we're seeing in our population and especially for women. So just a couple of points about who Prevent Blindness is. We are a patient advocacy organization, and we have a pretty straightforward mission in terms of what we try to do. We are here to prevent blindness and preserve sight. We see that there's a lot of challenges with that, which is why I have a job, but like I said, I appreciate being able to share the association between obesity and vision impairments. So at Prevent Blindness, we certainly believe that reducing incidence of obesity and its risk factors is an overall strategy for preventing vision loss, visual impairment, low vision, and blindness, and all of these are very different things. Diabetes is currently the leading cause of blindness in adults in the United States, and there are significant disparities that can be observed in the data of prevalence of type 2 diabetes across racial and ethnic minorities, but also most certainly between men and women. In fact, a 2017 study by the American Diabetes Association, researchers found that treating obesity can reduce the incidence of diabetes by up to 58%, which is pretty significant. Increasing evidence also shows that obesity significantly increases the risk of developing various eye conditions, including increased inflammation, glaucoma, cataracts, age-related macular degeneration, or AMD, diabetic retinopathy, and microvasculature of the eyes. In the United States, we can expect about 1 of 3 individuals who are working adults to develop diabetes-related eye conditions, and we see that men are more likely to get a diabetes diagnosis, but it is women that we find who are most susceptible to the most severe consequences of diabetes, and that also includes vision loss and blindness. So just a quick rundown of these conditions. All of these are exacerbated by high or uncontrolled blood sugar levels in the body that place additional stress on the body's vascular systems, including those systems that are found within the eye. Diabetic retinopathy occurs when there's damage to the blood vessels within the retina, and that causes leakage or bleeding that affects vision. So people with diabetic retinopathy report experiencing blotchy or sometimes patchy vision. Diabetic macular edema occurs when there's a buildup of fluid or leakage into the macula, which is the central part of the retina, and that has occurred leading to blurred or distorted vision, sometimes dark spots, again, that patchy vision. Also, there's problems that are reported of seeing color, which if you're driving, that's especially problematic. A cataract, this is something that probably everyone is familiar with, but it is a clouding of the lens of the eye, and that causes the vision to become blurry, almost as if you're putting a sepia filter over your eyes. And even though most everybody in their lifetimes will receive cataract diagnosis in their life, people with diabetes are about 5 times higher risk of developing cataracts, and so that's incredibly dangerous. Speaking of dangerous, glaucoma is a very dangerous condition leading to vision loss. It is a loss of peripheral vision, so just on the side. And just to clarify, you're not actually just losing your vision. It kind of continues to close in until you can only see your central vision. So really dangerous. This is something that patients don't often notice until that damage has happened. And once that has actually happened, it cannot be reversed. That damage is permanent, and so then it becomes about slowing the progression of the disease. Age-related macular degeneration, this is something that my grandmother had. More women are susceptible to this than men are. It is a progressive condition that doesn't lead to total blindness. It leads to more of a loss of central vision. So just imagine it's like something in front of your eyes just constantly and it never really goes away. That's what AMD is. And this is also linked to diabetes because the common risk factor between both is age. So I'm going to focus more on diabetes, given that obesity is a major risk factor for diabetes, and with it, many of the serious risks to one's vision that I've just covered. The eye itself includes many vascular structures that allow us to observe first where in the body other vascular damage is happening. So it's not really uncommon for people to receive a diabetes diagnosis as a result of an eye exam, because more often than not, the eye is where we can observe where damage in the body is happening as a result of diabetes. And one point that I really want to make about diabetes in particular, many people are not aware that vision loss from diabetes does not occur solely because of mismanagement of the condition or the long-haul nature of this chronic disease. Rather, we find that damage to the eye is already happening at the onset of the condition. So let me repeat that one more time. When you receive your diabetes diagnosis, you're already seeing damage happening to the eye. So that's really, really important to keep that in mind. At that point, it then becomes a matter of time to keep that damage from resulting in vision loss, but that damage is nonetheless there. So it's important to reiterate too that vision loss, once it has occurred because of these or other conditions, it is irreversible, it's permanent. So anything that we can do to keep from getting to that point is especially crucial. And again, that point is not letting diabetes just get out of control and run wild and become a big issue. It is that diagnosis. So we're trying to prevent that from happening even before that diagnosis occurs. This especially makes early detection important, but prevention is definitely much better. So this slide is an observation of what people with diabetes-related eye disease often experience. This is ultimately what we're trying to keep from happening. This does not need to happen. Like the Congresswoman said, there are things that we have sometimes accepted as a society of, I'm getting older and, aging is just part of the process and my eyes, we joke about it, but we really do not have to accept this as inevitable. There are other things that we can do to prevent this from happening so that we can all live a lifetime of health and vision. Treating obesity when it comes to these sorts of interventions can help prevent these complications from happening in the first place. That includes vision loss and blindness. Again, it does not need to happen as long as the right interventions are in place. So for people with vision loss and blindness, achieving optimal physical health presents many new challenges that someone with optimal sight and optimal health might not personally experience or be aware of. So obesity already has limitations on physical mobility, but when combined with visual impairments, together navigating physical spaces becomes increasingly difficult. It also poses new risks to the person for injury or falls. Vision impairment also creates new challenges to physical activity. That's difficulty accessing both indoor and outdoor exercise equipment and facilities, or a lack of programs at the community level that are designed specifically for physical activity for the blind or visually impaired. And also there's a general lack of understanding of how to include people with vision loss or blindness into community events, such as 5Ks and others. There's also home devices that aid in self-maintenance of one's personal health, and these things include glucose monitors, blood pressure monitors, scales, or even some fitness watches or devices that may not include visually accessible features. If they do, we find sometimes that they do not have the right technology in place to protect one's privacy and dignity. So imagine for just a moment you are at your community gym, you step on a scale, and you have the device announce to you what your weight is to yourself and everyone in earshot. Super cringe. So people experience vision loss or blindness, and especially if this happens suddenly or over time, or if damage has progressed so much that its effects can be observed in one's eyesight, often experience emotional or psychological distress, including grief or trauma. This is certainly a very normal response, especially if you're not used to it and you've lived your life up to a certain point with health and vision. And suddenly things just become very, very different for you. You're going to grieve that, aren't you? It's well documented that physical movement and activity can help aid these very normal processes, and yet when you're facing visual impairment and obesity, that may not be an option for you without the right supports in place. So as such, lack of movement can then lead to further emotional distress and social isolation, and this really only worsens the problem. So ultimately, by addressing obesity, we are addressing vision loss and blindness and the serious consequences that may happen as a result of it. So as part of this strategy to address obesity, Prevent Blindness stresses the importance of early detection for people who are at high risk of diabetes and related vision loss. And this can help determine where early damage may be apparent and help to get that person on the right journey to managing it before diagnosis even takes place. This can also include access to the right treatments, such as AOMs and others, and that can be a tool to help prevent obesity and therefore a tool to help prevent vision loss as well. We also stress the importance of supports in the mental and behavioral health space that can help someone navigate the changes that come with vision loss. And that's whether that's due to one of the conditions I just spoke of earlier, or even if it happens on an acute basis during injury or an infection, or if someone has a progressive condition due to a rare disease or due to age. So by tackling those mental and emotional aspects of vision loss, we're also addressing the risks of obesity with that. And finally, a successful system of obesity and vision care in the United States is not only dependent on someone simply making good lifestyle choices around diet and exercise. While these are important, we do need a system in place that prioritizes and supports an individual's daily lifestyle decisions. And that's access to the right foods, the right facilities and equipment to move freely, the time to prioritize one's health and well-being, especially important for women with families, and of course the right care at the right time. And all of these components of this system must also prioritize the accessibility needs of people who are blind and visually impaired. So if we truly wish to address obesity and chronic disease in the US, we must consider policies and programs that enable and not disable. Thank you again.
So first, NCOA, our mission is to is to create the conditions for all to age well in America today and in the future. We work to strengthen our communities, and we're advocating to support change. We support older adults and work nationally and in community, bringing older adult voices to the forefront. And in terms of the Obesity Care Advocacy Network, this is a group of 40 members that is a mix of medical associations, of advocacy organizations, and industry, and we're also advocating for the rights of everyone to get obesity care and treatment, and to get the care and treatment they deserve. Strain on the healthcare system will be evident by 2030 because we will have 1 in 5 Americans at 65 years or older, significantly increasing the demand on Medicare, Medicaid, and long-term care. So it's an important issue, especially when you think about how many people in this population will be older adults as we continue to move forward. Our vision is that every American should have the tools to take control of their health, and access to obesity care through Medicaid supports self-reliance, not dependency. I wanted to share some of the numbers of behind obesity and aging with you. So here you can see, well, I wonder if you were aware, the majority, oops, too fast, of older adults have at least one chronic condition, and many have 2 or more. Obesity prevalence is 42.8%, which increases, as you've heard from some of my panel members, many comorbidities, but increases risk for heart disease, type 2 diabetes, cancer, and over 200 plus chronic conditions and diseases. Another number that's critically important is the Obesity Care Advocacy Network recently did some polling, and 78% believe it's important for Medicare to cover medications, proven to help people manage weight and improve overall health. 48% higher risk of physical injury. So we know older adults and people living with obesity and overweight are 48% higher for an increased risk of falls and fractures, which lead to higher medical costs and mortality rates. And another important number is 64. Many people who are 64 years old who are receiving treatments for obesity through their private health insurance, when they turn 65, will not be able to have coverage for medication through Medicare. So that we call that the Medicare cliff, because they will fall off the cliff when they get into Medicare, and that's just not right. That's critical for many older adults, for many individuals who are getting treatment and care from their healthcare provider. So at the National Council on Aging, we engage older adults and listen to their voices. One of our main goals is to bring the voices forward. And over the last 2 years, NCOA and the National Consumers League, some of my colleagues who are here in the audience, hello, thank you for being here, traveled across the country, and we listened to patients speaking out and heard the barriers they face. And from over 300 voices, including from healthcare providers in those local communities, we created an Obesity Bill of Rights. These are basic human rights for all citizens. And it was very powerful listening to those voices. In fact, in some cases, we heard people say they felt invisible. And one person in Alabama stood up and said, "We live quick, we live sick, and we die quick." And they were talking much like the congresswoman about his relatives and how it was very common to have young deaths in the family, especially when the women were living with obesity. He spoke about his aunt and his mother. And so we put together these Obesity Bill of Rights. These are rights that every person, every individual should have. And these rights are available in the process of how we created them at a microsite called therighttoobesitycare.org. There's a lot more details, but on the face of it, this is critically important for everyone, to have the right to accurate, clear, and trusted information, the right to respect. We heard a lot of people talk about ageism and stigma. People were talking about the way that they were treated, and it wasn't pretty. The right to make treatment decisions, to have the options to make decisions with their family and their healthcare providers. The right to treatment from qualified health providers, people who are specialized in obesity medicine. The right to person-centered care, the right to accessible obesity care and services from health systems, and the right specifically for older adults to receive quality obesity care. And finally, the right to coverage for treatment. So I want to speak with you a little about the fact that many older adults with obesity can't access comprehensive treatments due to policy barriers. And we know that the Treat and Reduce Obesity Act has been introduced to this Congress. It has been introduced about 13 times to many past Congresses. But it's critically important, and we wanted to educate and inform a little bit more about it today. So the Treat Reduce Obesity Act would correct the prohibition of obesity medications under Medicare Part D and expand the type of healthcare clinicians and places eligible to provide intensive behavioral medical therapy for obesity under Medicare Part B. And so we know that, as I spoke about the Medicare cliff, obesity, Medicare doesn't cover weight loss medications, even FDA-approved medications, unless for certain conditions such as diabetes, sleep apnea, or heart disease. But what kind of situation do we want to have? Are we waiting for individuals to become sicker before they can get coverage? In terms of the Part B benefit, we know that intensive behavioral therapy is important for lifestyle and behavior change, and anybody who's going on a weight loss plan really needs to focus on their protein intake, their exercise level, hydration. It's critically important. This intensive behavioral therapy would help older adults and all individuals really have the counseling that they need in the locations where they are. Right now, Medicare only limits the behavioral therapy to physicians' offices and by physicians. And we know a lot happens in community. So there is what you have. And then, of course, CMS, the Office of Center for Medicaid and Medicare Services, they have the ability to develop a framework to cover obesity in Medicare Part D. And they also have the ability to update the National Cover Determination, which is very outdated for intensive behavioral therapy, for obesity and Medicare Part B. So there's many ways that are right now before us in this environment that change can happen. And I so appreciate the opportunity to be here and talk with you about this, and I appreciate your time. So thank you very much.
So we have a few minutes for questions, and I'm going to start off, but just raise your hand and we'll manage it as we go. I think a couple of sort of thoughts I wanted to share. Sarah, I really appreciate you connecting the dots for us. I don't know that we often think about this issue from the perspective of impact on, you know, vision. And when we think about that and the diabetes connection, I think that that's a really interesting way to think about it. But it also, I think, is an example of, and I think, Dorothea, you said this right, it's outdated, right? We have an outdated way of thinking about this, and the way that Medicare and other insurers think about obesity is very outdated. And it has not kept up with sort of the current thinking and experiences of patients themselves. And so really thinking about how can we modernize the system, not just to keep up with the times, but to also ensure that it's rooted in the science and rooted in prevention. And so I think that's one way that we can all kind of think about this broader conversation. So I want to maybe just start with sort of a very simple question for each of you, and we can go down the line. What do you believe to be the greatest challenge for women living with obesity? What are they facing today?
Sure. I would say that they very relevant to a variety of comments made here that I also made are there's really a lot of weight stigma and bias that affects women, quite honestly, far more than men. And there is a feeling that this is cosmetic, that this is superficial, and it's really not. And we have to stop thinking about obesity that way. We have to stop shaming, women and all members of society who are having weight dysregulation. If 75% of the country is having a weight issue, and they're spending billions of dollars on this out of their own pockets, not through medical care, not through health insurance coverage, and there's still 75% of people having an issue with weight, and it's getting greater and greater, then we have to think about what this means and how to address it within the medical home. When someone's thyroid malfunctions, we don't blame ourselves and that we need to go on hormone replacement therapy for thyroid. And obesity is much the same way. GLP-1 medications now are essentially hormone replacement therapy, and they are necessary for many as part of the treatment of obesity. And that's what I would encourage women and everyone out there to feel empowered by this. And to advocate for it. If we don't advocate for it, it will not get done. We need to get the job done by standing up for ourselves and treating obesity as the disease that it is.
I think with respect to the woman care patient, there's a lot of different angles. First of all, eye care is not as prominent as simply just going to a my eye doctor. That can be one area of intervention, but it's not always accessible to people. Sometimes you have a lack of insurance, or it's underinsurance, or it's a cost issue, especially if you are raising a family. And when we do tend to put our families and other people before our own needs, we still do that in a lot of ways. But also there's just not enough eye care providers to see everybody. And I think also too, it's a lack of understanding of just how serious it can be. If you have a diabetes diagnosis, you are at risk for vision loss. It's not something that's gonna happen down the road. You're already experiencing damage, and really putting it in those sort of plain terms, not meant to scare, but to empower women. Prioritize yourselves and your health care first. I definitely agree with what Dr. Alexander was saying. There's still a stigma around it, and I think women are often told, social messages that this is something that we can control, or it's our own personal feeling. We take all of that on ourselves. We don't realize that there is a system out there that can be supportive of our own healthcare needs, and we also don't think about prioritizing our eyes on top of everything else. If you're facing a whole lot of other things, your eyes are going to be the last thing that you think of. I don't like playing second fiddle, but that's just the reality of things. And we need to tell people that, your eyes, if you lose your vision, you could lose, not just the ability to see your children and your grandchildren. That's, in many cases, if you let it get too far, that could be your livelihood, your identity, and you can, always come back from things and, be somebody who lives with vision loss and still have a very good life, but it doesn't need to happen, especially if you are as somebody who is at high risk and you understand what those risks are, there is help out there. And so encouraging women to, take it on ourselves to find the right care. But as I was speaking, towards the end of my discussion, creating a system that makes it easy for women to receive the kind of care and treatment that we deserve.
Thank you. I agree with everything that's been said. I think there are quite a few challenges. I would just point out that when it comes to older adults, they're not a homogeneous category, and neither is anyone else. But somehow we have this sort of stereotype that if you're an older adult, then things will come and happen to you in terms of age, and that you shouldn't worry about it because this is what happens and it's inevitable, and that's not true. Everyone is unique and different, and the 60s are different than the 70s. Your needs may be different in the 80s, and you may be older adults, but you definitely deserve to have the right to have patient-centered care focused on your individual needs and your circumstances. And I know ageism is another factor that plays into the older adult experience, and that's critically alarming because people especially healthcare professionals, can often look at older adults and be dismissive. And that, on top of not paying attention to the fact that they may be living with obesity and facing stigma, creates even a bigger problem. So I think that's one of the important issues, and the fact that older adults can't get support from Medicaid and Medicare and possibly Medicaid now in some states to cover the care that they may need in therapies with the consultation of their doctors, because the insurance companies won't pay.
Thank you for that. I think there's a couple of things here. One being when we think about what the legislation, but also sort of this interaction with CMS is really looking to do is to make sure, as the Congresswoman said, right, that there's actual equal opportunity here, right? That you have access, everyone should have access to the full spectrum of comprehensive obesity care. So that's one thing. The other piece that really sits with me, and I was thinking about this yesterday, more so from the perspective of employer health benefits, and how we're often hearing that folks might be covering certain things and then they decide they're not going to. And so it's a really uncertain time. If you're 64 and you have access to a particular treatment and then you turn 65, you lose that treatment for a chronic condition that is only going to, may get worse, and you're managing it well, that does not seem right or fair. And so just thinking about how to make sure that everyone does have access to these treatments is really critical. Any questions from the audience?
First of all, thank you all speakers for your perspective. Very interesting. My name is Sanjay, by the way. I'm the founder and CEO of the Tech Connect Virtual Studio on the House. I'll be very curious because you cover the different perspective of obesity, and I understand the key focus is to treat it as a disease. But you also mentioned about there's different aspects, right, around obesity, like social isolation and also the choice of the food and education part. So when it comes to addressing the policy as a pathway, as a tool, which one do you think is the most effective in terms of investment, let's say, in the dollars and efforts and advocacy, compared to the outputs and eventually how effective it is to either prevent it or to cure it or just kind of to have the post-care? Thank you.
I can take that. Do we have to take one? I would say, the first thing, prevent blindness. We need to prevent it before it gets to a certain point. If I had to pick one thing right this second that's very timely, it's, not cutting a lot of programs that focus on disease prevention and health promotion. This is where people get critical information about what kind of foods to eat that, carry certain things like antioxidants and how to make these healthy choices and understand the behaviors and how those are linked to some of these conditions. I think that's a great place to start. I just don't see how we can address chronic disease without having that support system in place.
I would say overall, all access to care. If we're to think about where the weak points are at this point in time, is that we don't have access to care to medications. for obesity, for obesity medications. Other diseases have access to the medications which treat them. We have highly effective medications which treat obesity, and we're requiring patients, because of the stigma and bias, to first fail other therapies repeatedly over their lifespan to finally be allowed to receive a medication in addition to all the other intensive lifestyle interventions that we know are necessary and foundational to treat obesity. And so I would say, advocating for Medicare Part D coverage, because we know whatever happens there then goes through 55% of the country receives, is government insurance. And from there, we roll into what other insurances are going to do, what employer-based programs are going to do. And it's just a matter of time. We cannot get ahead of the amount of money and the cost that is being spent in the United States to treat preventable diseases whose root cause many times is in weight dysregulation. And if we treat the roots, not the fruits, we can get somewhere. There was a report, the ICER report, which showed that treating obesity is cost effective. It's been cost effective and known to be cost effective from a study back in 2021. Now, affordability is a different issue. Is it affordable? And the question is, well, we're not going from zero to spending a whole lot of money. We're spending it elsewhere. We're spending it elsewhere to treat something after, sort of we're at stage 2, stage 3 style of obesity, and we could be treating it sooner and treating the roots and preventing other diseases. Cardiovascular disease is expensive as well. Cancer is expensive as well.
Dorothea, before I jump to you, I
I
wanted to add
I
the
would
kidney,
just
the
say
kidney
that,
connection too.
It's important to empower people with the tools that they need to take care and manage their chronic conditions. And so if we're doing it for other chronic conditions and diseases, I don't see why we wouldn't be doing it for obesity. And I think it's critically important, right, that the healthcare system work for individuals and not against them.
Yeah. Fortunately or unfortunately, I think the answer really is it's all of it together, because you really do need these pieces, right? It's not just going to be related to lifestyle, right? That's a huge issue that we hear a lot about. If it were calories in, calories out, we wouldn't be in this state. If there weren't clinician bias, which we heard a lot about yesterday in our working group, and it's something that is a common thread across women's health, but not being treated in a way where your concerns as a patient are being heard and not being listened to, you're not going to be able to access treatment and not be able to have a conversation. If you don't have the programs that are equipped to be able to help you and arm you with the tools that you need, then we are also sort of falling further behind. So it really truly is a comprehensive approach to it that will ultimately, at the end of the day, save lives, save health, will prove to be improving longevity and wellness versus just aging and living longer but not well. For women in particular, we spend 25% of our lives in poorer health than men, even though we live longer. And so there's definitely some inequities there that probably need to be addressed. Okay, so I think we're probably out of time. I want to just do rapid fire, and we'll start with Dorothea and come down. So as we think about the folks in the audience, whether they're congressional staff or folks in industry, other nonprofits, et cetera, what is the one thing you want them to take away from today's briefing? So we'll start with Dorothea. Come down.
Support the Treat, Reduce Obesity Act, please.
Not to be too trite, but save lives, save eyes.
Treat obesity as a disease, but I also say TROA, because if we start there, we're gonna get everywhere. We need coverage. You need insurance coverage. It's a disease.
Yeah, we came real close last Congress. Let's get this done, guys. So thank you all for spending